pretty eyes.
Good morning, Tracy.
Good morning. How you doing?
I'm doing good. How are you?
I'm doing okay. Hanging in there. I was
Are you?
thinking because I have you on no, it's fine. Leave it open.
When do you get back?
That you have very pretty eyes. Are they
Oh,
blue
thank you.
or
They're
like
green.
like a grayish?
Yeah.
Yeah. From here, when I first saw it, they looked at blue. And um my new grandson,
Uh-huh.
he is like a towhead, okay? And he's got like hazel, light blue, kind of almost a gray eyes. And so
Uh-huh.
that's why now, of course, for at least a couple months now until his eyes settle into a color.
Sure.
I was like, hey, oh, that's funny.
So are you on tech? You're out in of technology. No, is that the
Yeah,
right place? Yeah.
yeah. Yep. Didn't know if I was going to be able to join today or not. I will be able for a little bit.
Good. Good morning, Jamie. Hello, Terry.
Good morning. Good morning. How are you all?
Doing good. How are you doing?
Good. I have about 400 tabs open, so I hope you can lead the program because last night and this morning I've been frantically reviewing all of the documents and now I don't know where any of them are.
Okay. Thanks for the reminder. I need to get the PowerPoint going.
I talked so much at our surge meeting yesterday. I have laryngitis now.
Oh my gosh.
So that's my clue to not talk as much at the meetings.
There. How long did the meeting go? I had to leave at 4:15, which was 15 minutes after it was supposed to have ended.
4:30. We went to 4:30.
It's terrible. Okay, I won't ask you any more questions, Terry. I'm sorry.
You're good. But the good news is I felt like it was a really good, productive meeting.
I agree. I'm excited to see what they end up doing with the next kind of set of time to create new priorities. Good morning, Linda. Good morning, Leah.
Ooh.
Good morning, Heather.
Good morning. How are you?
Good. I owe you a response. I haven't responded. Let me put that on my to-do list for today.
Okay, I wasn't sure if that was me. I was about to say the same thing.
Yes. And I had forgotten until I saw your name, and I was like, I owe her a thing.
No worries.
Thank
You are
you.
busy. Also, hi Jamie. Sorry, I was having technical issues with my camera and microphone this morning. Good to see you.
Good to see you too. Thank you.
I've got my eye out for Sway. I haven't seen her yet.
Tina, do you have her cell phone? Can you text her?
Sending her a message. Well, I'll look for her. I do have her phone number. Oh, there she is. Yay.
Perfect.
Perfect. Okay. So whenever you're ready, Jamie.
Good morning, everyone. Thank you so much, Sway. So good to see your face again.
Yes, thank you. Sorry, I was trying to, like, it kept saying my URL or something wouldn't work. So I was like, what?
Oh, isn't that fun? Okay. Tina, do you mind sharing the PowerPoint so I have all of the right words to say for
Sure.
all of those things?
Mm. Okay, can you see the PowerPoint?
Yes.
Okay, so.
Yep.
Okay.
Thank you. And I think we can move to agenda item 1, which is our welcome. And I believe we now do roll call. Tina, do you mind doing roll call?
Sure. So Jamie Ross
Here.
and Wansuela Mackey.
Here. And Tina, do you need everyone who is not a member of this subcommittee to give their names so you have them for the minutes? Or do you have another way to get that information?
So thanks for asking. As long as people are logged in to the meeting, then we should be able to create an attendance sheet from that. So just make sure
Perfect.
your login name is how you want your name on the minutes.
Thank you. And I do believe we have a quorum.
We have a quorum.
Perfect. Can we move to agenda item 2? All right, this is the first of 2 opportunities for public comment. To provide public comment telephonically, please dial 775-321-6111 and enter conference ID 634-991-514#. Comments should be limited to no more than 3 minutes. No action may be taken on a matter discussed under this item until it is included on the agenda as an item on which action can be taken.
And of course, members can participants can use the raise hand feature.
Thank you. Has anyone called in, Tina?
No.
Okay, and we don't see any raised hands. I think I'm okay to close agenda item number 2 and open agenda item number 3. Which is review of the funded programs and projects by the chair. Do you have the funded programs and projects funded by the chair open so you can share that?
So just as a precursor, we did have the statewide plan goals that Don Yohe mentioned to us in January. So I put that in the PowerPoint to basically say where the goal areas were for the expenditures for the fund. And then, of course, during that meeting, Dawn also told us of the restrictions for the funding. So this is just a review. So again, just to say there's limited use perhaps or restrictions on where some of the funding can be allocated.
Wonderful.
And then I put in the strategies for the funding, which is also in the state plan that was created in 2020. And just talking about some of the activities that the original plan had indicated would be sufficient or appropriate uses for the fund. So this was related to prevention, since the group here is interested in prevention. There were several areas of strategy, a lot of education with ACEs, welfare best practices, which Sway might be able to talk to speak to different specialty courts and education and training classes, especially K through 12. So there was quite a few strategies in that plan. And some of the actual funding, here's the listing that we received at our meeting with Dawn. I'd had asked for a larger list so you would have more specifics on some of the programming. So this is the summary that we were given. So about $4 million has been allocated to this prevention area. And some of the programming is listed here. I don't think it's a complete list, and I did ask for more information about that for this group. I also know that the dashboard that we originally had viewed has been updated. One of the things yesterday in looking at that during the surge meeting was that there is allocated funding, but sometimes people are not actually spending it or spending it in full. So just an interesting question, perhaps later to find out about.
Yes.
And I think that's the last slide. So that was just a little bit of information about historical funding in the last year.
Perfect. So I do believe per the last meeting we had, we are able to allow comments from the public if we so choose. So if you are a member of the public and have thoughts, ideas, etc., please share them as we go through. Tina, do you mind going back to the first section of whatever this agenda item is?
Did you want the actual, or did you want the description of the strategies?
The second, yeah, page 5, please. Perfect.
5.
4? Is it 4? Did we, yeah, where is the, all the goals and the strategies?
Okay, so here's the strategies.
Okay. So, Sway, I know you can talk to more about what's happening with families and children. So in strategy 1, prevent opioid use from progressing to misuse and overdose. Objective, identify risk factors for opioid use and misuse, activities, disease investigation, fatality review, substance ID, and testing. So my concern with the activities under this strategy is if we want to prevent opioid misuse, disease investigation and fatality review, as well as identifying substances in people's systems, while very important, aren't going to be particularly helpful in preventing opioid use. And by the time someone is dead, we definitely have missed that boat. So I think those are all very important, but I don't know that I would put them in that category. Heather or anyone who is brilliant at this, please tell me why I'm wrong.
No, I would agree with that, but identification of risk factors are really kind of demonstrating where that transition is, but not necessarily prevention of early initiation.
So I may change some of those activities to the youth risk behavior survey, the school climate surveys that are done, more specific youth understanding of the issues that our youth are facing. I know there's probably more than those two, but those are the two that I regularly review for when we're looking at prevention programming. I know the YRBS has added almost all of the ACEs risk factors, which is really helpful information for us to have. And for anyone who's interested, the 2025 YRBS just came out. Okay, objective 2.1 under preventing use from becoming misuse and overdose. Educate the general public on opioid prevention and treatment, including public information campaign or education campaigns, pushing 211 for information and stigma reduction. I think those fit well within there. And then 2.1.3, equip providers to prevent opioid misuse and overdose, educate on alternative pain management methods, increase prescribing training, anti-stigma training, clinical guidelines for non-pharmacological pain management. Does anyone have any thoughts or ideas on that one? Okay.
This
ahead.
is Sway Mackey for the record. I was going to say, I think, education is always going to be this launching pad to some of the prevention. But when you're talking about how, I guess, how are we educating? Are we educating through pamphlets, flyers, hospitals providing that information? I think, we just kind of need to dig a little bit deeper into how is that happening. But I think it goes there.
I would agree. I love the question of how is this happening? Any other comments on 2.1.3? Fabulous. 2.1.4, promote safe pain management for patients with chronic pain or opioid prescriptions. This is safe storage, disposal, patient education. I believe this would theoretically coincide with one of the surge conversations that we've had, Terry. And again, I'm not going to make you speak, but I know the surge committee had talked about safe storage and disposal and potentially advocating for more disposal options. So I think that would fit there. Anything else under safe pain management? Wonderful. I think we can move on to slide 8, please, Tina. All right, strategy 2.1, we're still on preventing use from progressing. And then 2.1.5, educate youth and families in the community to reduce the risk of ACEs, child welfare involvement, and opioid misuse and overdose, including ACEs education, family-based prevention strategies, ACEs screening in schools and medical settings. Sway, do you have any thoughts or ideas on this? Have you seen any of this in action?
Yeah, we do. In the Child Welfare Agency, we do review substance misuse for use as opposed to substance abuse for some of the adult parental clients that we have. It's always going to start, in the home, I think, right? The prevention piece and educating youth. But you have to also make sure that the home is healthy enough to educate the youth, right? If the parents aren't healthy, that's going to kind of barrel its way down to the home. But I think we need to make sure that it's happening in all areas, the schools, the community centers, all of the places where we find those youth activities happening, and giving them a safe space to be able to talk about that there is, that they even are thinking about it or being approached about using substances. So I think it's a good spot to stay in that area right there.
Thank you. One of the things that I noticed when reviewing the 2024 report is there was some really great things being done with the multi-tiered systems of support. And there was a kind of a postscript at the end of that section that said there will be no more funding for that program after 2025, after I think it was like June 30th of 2025. So I thought that was interesting If our goal is to meet children where they're at, school settings seem to be the best place to do that. And
I think this is Soy Maggie for the record. As I'm reading the activity of, family-based prevention strategies and screening in the schools and medical settings, I think there may be a gap for those children who aren't going to doctor's appointments, right? Those children who aren't getting, a yearly checkup, and then those children, especially those, preteen, teenage children who may have some education neglect happening in the home as well. So just keeping in mind that there may be a gap in that population of children.
how would you recommend do you have any suggestions on other areas we can add into this activity because I agree with you, there are definitely children who are not getting education. Their families are not connected to child welfare services for one reason or another. They're not going to school or to doctors. What would be some opportunities to reach those, probably, I think I would call them hard to reach populations?
Mhm. I think it's maybe similar to how we treat, our CSEC children, right? We try to put messaging in those spaces where they know that, hey, you can call someone if you are in trouble, maybe coming up with kind of an outside of the box way of, where are those youth hanging out at? And going to those places and trying to ensure that they have some messaging there. You can always work with truant officers because the truant officers are going to the homes and saying, why aren't your kids at school? But, we don't know what's happening in that home setting. But those youth are, they're out in the community. And I think we probably have to maybe take a deeper reach into the community and figure out where we can put that messaging and where we can advertise that there is support for those children.
Yeah, I agree. I think those are some really great strategies that we may want to. I know Tina's taking great notes and we'll come up with minutes from this meeting that will be super useful for when we have our larger meeting. Any other comments on objective 2.1.5?
Sorry, this is Sway Maggie for the record. I just wanted to give that quick example that just popped in my head. I know like a lot of youth go to the First Fridays event, right? That happen in downtown. So that's kind of just like a sample of kind of what I'm thinking when you're talking about targeting youth where they are hanging out at.
I think that's a great idea. And I think there's probably, based on my anecdotal information, having been to a multitude of First Fridays, I think you're probably going to get a higher than average percentage of those kids who aren't getting the activities in those 3 that are already listed.
Yes.
Okay, 2.1.6, support youth and adolescents who have experienced ACEs and are at risk. Activities in this are child welfare best practices, safe baby courts, and home visiting programs. I'm going to throw this back to you, Sway.
Yeah, definitely fits in that area. We do have safe baby courts that has been implemented. We are, with regards to home visiting programs, again, it kind of, I don't want to say it's not that simple, but it's not that complicated either, right? Trying to reach youth. I think in child welfare, what we find is it's usually not just one thing, right? There is some trauma in the home, then there's some opioid misuse in the home, and then there are runaway You know, children are running away and staying away from the home. So I think we have to figure out how to merge those things, you know, the trifecta. There may be some domestic violence happening in the home that's causing youth to leave the home. So I think we have to figure out how we address those things and what the root, kind of do a root cause analysis, you know, to figure out what's happening and why, how we can support those youth based on the trauma that they are experiencing.
Love that. And I think that there are a couple of people who've joined us. So if you're a member of the public and have thoughts or ideas on any of these goals and objectives, please jump in. We would love to hear your feedback as well. 2.1.7, prevent opioid misuse and overdose in schools, prevention specialists in K-12 schools, aftercare / intramural programs, education training, or educator training, apologies, school survey results on drug trends to leadership. Any ideas or thoughts on this one? My one comment on the objective is prevent opioid misuse and overdose in schools. The way this is worded, it sounds as if we're trying to prevent overdoses in schools specifically, as opposed to overdoses for youth, which I do believe is what the goal or the objective is here. So I may suggest prevent opioid misuse and overdose, I don't know, with or for students in conjunction with schools. Again, I'm gonna put Heather on the spot. I don't think we have a significant problem with students overdosing on campus. Again, we want that number to be 0, but I can't imagine it's particularly high if it isn't 0.
As far as I know, and I don't have data for all counties, but in the school districts where I've spoken with some folks, it's pretty sporadic. I think the majority of concern with substance use in the schools is really focused on vapes. And we don't know what kids are vaping necessarily, but that's a lot of what I'm hearing about specific to substance use in schools. There have been a handful, especially in our urban communities in high schools, where naloxone has saved a life. So if this is an objective that stays maybe kind of to your point, mirroring the objective in the activities, I think those activities are important. I don't know if they align with this objective, and maybe if the goal is to, or the objectives is around overdose in schools as opposed to preventing overdose among school-aged youth, then naloxone in schools and high school settings might be an activity under this. But to my knowledge, it's not the primary concern for substance use among youth when it comes to the school setting.
Yes. And I did see that there is a federal bill. It's that came out. I've got some colleagues who were at the RX Summit this week, and there is a federal bill looking to provide naloxone in schools or provide education for first responders in education settings. I'm assuming that means teachers, social workers, school nurses, etc., on naloxone, which makes me really happy that Nevada was on the forefront of that curve, specifically around naloxone in schools. We've had that law for many years now. But I would agree with you, if that is the goal, then we need to speak more to naloxone. Moving on to slide 9, I think. Strategy 2.2, detect potential misuse early and intervene to prevent increased severity, which would include monitoring the prescription of opioids and related substances, including, and the activity would be enhanced PDMP analytics, including on bordering states. My biggest concern with the strategy all the way down to the activity is I don't know what percentage of our substance use, specifically around opioids, is starting with prescriptions anymore. With fentanyl kind of proliferating in many different aspects of the drug supply, I would wonder if this might be a better place to talk about the drug trash screening, working specifically with those populations. Definitely not saying we should get rid of the PDMP. I just wonder how much data we'll get from the PDMP because the prescribing guidelines have changed. And I mean, we saw in one of the reports I was looking at, the prescribing has gone down significantly since those laws changed in 17 and 19, I think. Whenever they changed for prescribers. I'm hearing no comments,
This
so
is Soy Mackie.
yes.
I'm sorry for the record. I see that the objective is to monitor the prescription of opioids and related substances. What are we doing with that? Like we monitor it and then what?
It's a great question. How is that information getting to the people who would need to have that information? Plus, who are the people that would need to have that information? Heather.
Yeah, this was an early on question I had when I came into my position in terms of what actions being done with the PDMP data. I do know, and maybe Terry can speak to some of this, but law enforcement utilizes some of that, and then I think they have to use that within conjunction with other evidence to build a case if they are working on a case against a specific provider. But from more of like a public health perspective, and this was many years ago in New Mexico state I used to work in, what their Department of Health is, they created provider report cards, and they basically took like the top 10% of prescribing providers and kind of gave them like a graphically appealing one pager on where they sit relative to other providers in their community, like in their county and respective to the state, to give them a little more context for this is, like you're in that top 10% of prescribers. And so I think that might be a potential feedback loop to explore that doesn't involve like the law enforcement side of what might be done with the PDMP data for consideration.
Thank you. I think that's a great idea. And Terry, your name was mentioned. You don't have to speak, but if you have something to add, you're welcome to.
Hi, Jamie. Terry Kearns for the record. I apologize. I have laryngitis. But what I was going to say is Heather's correct about law enforcement's involvement. But one of the other things that came to mind for me in this is perhaps looking at the number of new prescriptions. For a project we looked on and for a surge, I was still surprised, even though the prescribing rates are going down, there still were a lot more prescriptions being written than I thought would be written. So maybe monitoring for new prescriptions and looking at providing resources, guidance, safe disposal, naloxone, co-prescribing of naloxone with new prescriptions of opiates.
Thank you. I love that as a suggested activity in there, is if we're going to be prescribing opioids, also prescribing naloxone, which has been a best practice for a while, but I don't believe Nevada has implemented as a rule, just a best practice and a suggestion for our providers. Moving on to objective 2.2.2, implement screening and early intervention for all Nevadans, including screen and treat for ACEs, 0 to 3 programming for families, increase the use of SBIRT, with provider trainings, provider and education on signs of trauma and referral resources. Would this also be a place to potentially add in, Misty, I hope you're actually here because I'm going to ask you a question. There is a suicide screening that is done in many schools, and I can't remember what it's called. And would this be a place to add that? I think Misty just jumped off, so I don't think that she's going to answer our question, but potentially adding the suicide screening that is done in schools, not in all schools, but in many. Because the risk factors for suicide and the risk factors for substance use are much overlapped. I know that SBIRT for adults mostly has been something that has been around in Nevada for at least 10 to 15 years, but adoption remains very slow. Two point three, define immediate solutions to reduce the risk for overdose and prepare for responses. With the objective being implement a cross-sector task force to address overdose, and the activities develop action steps to reduce overdose risk, prepare responses for communities when overdoses increase, and provide technical assistance. So to my knowledge, the only potential agency that's been working on objective 231 cross-sector task force to address overdoses, there's a Clark County opioid overdose task force. And their number one recommendation when I heard their last meeting, and if anyone has more up-to-date information, please share, is because they do not have a closed meeting allowability. There's a lot of information that cannot be shared, and the data isn't as useful as it could be because they're not allowed to do a deep dive on specific overdoses because of open meeting law, and I'm assuming it's HIPAA, whatever the rule, the legal language is, that we can't talk about specific people, even after they're dead. So wondering if there's appetite to increase the amount of overdose task forces, and potentially also, I think you would need to reopen Nevada law NRS to allow for closed meetings for these projects. Terry.
Hey, Jamie, it's not exactly a task force, but prior to COVID, so probably like 2019, under some grant funding, each community did develop an community overdose response plan. Some are pretty in-depth, some are more the bones on the getting that together. So a suggestion might be for the communities to pull those off the shelves, dust them off, and reinvigorate those community overdose response plans.
I think that's a great idea and a great suggestion. Are they're specifically called the community opioid overdose response plans?
I think it's community overdose response plans.
Perfect. Thank you. Okay, I think we can move to slide 10. So the funded projects for just under $4 million, we have integrating certified prevention specialists in schools, implementing sobriety treatment and recovery team programs for families involved in child welfare, enhancing youth activities for youth that may be at higher risk of use, including sports programming for boxing, volleyball, and basketball, and substance use prevention programming, providing early intervention systems, providing before and after school programming for youth and adolescents, and focusing on family planning. Sway, do you want to talk about the START programs and the early intervention and the family planning? Those feel like they might all be in your wheelhouse.
Yeah, I think, we, again, like I said, I can definitely start by looking at how many substance misuse reports that we receive in the agency, but I'm wondering if those will fall under a different area. So I want to make sure that we could capture the population. I'm thinking some of those may, is it that they're coming to the attention of child welfare because of substance misuse, or are they coming because of inadequate supervision or educational neglect? Or so it'll be kind of a deep dive to figure out, what that total population looks like. We do have a at-risk youth team here, so maybe they are capturing some of those youth as well, because of, again, they look at like our CSEC population as well, where I can imagine that, some of the area of substance and opioid use is happening in that population as well. So definitely could, take a look and work on our side of the house to see kind of where we're seeing the population of youth and substance use.
Thank you. Yeah, I think that's interesting. One of the kind of notes that I would make is on those START programs, I hear sobriety treatment and recovery team, and I don't think prevention at all. I think harm reduction or treatment and recovery, which obviously is fine, but I would just be curious the thought process behind putting that under prevention. Again, I don't know anything about the START program, so I wouldn't want to ask that question without better understanding those programs, but that would be one of my questions. Under enhancing youth activities for youth, such as all of the, the sports, I would love to ensure that that project is using evidence-based prevention programming. As I was looking at some of the annual reports, some of the programs that were named, I do not believe meet best practices anymore. And so I would just want to make sure that we were using the most up-to-date evidence-based prevention programming that we're able to get our hands on. To ensure that those programs we know what happens when bad prevention happens, we get DARE. Early intervention, I don't have any other suggestions or ideas on this. Does anyone else have any?
This is Sway Mackey for the record. I'm probably gonna age myself when I say this, but I'm thinking about the campaigning for some prevention, and specifically, for those of you who may recall, like there used to be campaigning of like, hey, this is drugs and this is your brain on drugs, right? Or it's 10 p.m. Do you know where your children are, right? Like some of those campaigns that actually at least will give you an idea of like, hey, I need to think about this, right? And it kind of triggers you to at least think about it, right? Even if you're not actively doing, but I'm wondering if is there space for any of the bringing back some of that type of, campaigning to
I know
have
that,
youth
yeah,
and parents think about that.
I know that the state's getting ready to launch a really big stigma reduction campaign, so I don't know that that fits in there, but I think that is definitely could go along with one of the things that those of us in the prevention field have been, working towards is what we call positive social norms, ensuring that kids and parents know that most of them are checking in on their kids daily. Most of them are not using. Most of them are abstaining because the science behind it is basically everyone wants to be part of the in crowd. And so if we remind everyone that most people don't do drugs and most people are connected to their kids and their families and cohesive family units, more people want to be part of the in crowd, and that's got some pretty positive outcomes. So I love that idea. I would just want to make sure that we're framing it as a positive based on newer data, because I think that's fantastic. Terry.
Yeah, I was thinking of some data that came out from one of the YRBSs from years ago about asking the question about youth using illegal drugs. And they had to change the question because they were like, well, none of these are illegal. Um, but, for people under 18 or 21, they are. So even looking at kind of changing the mind's frame of what's illegal or acceptable to use versus what's, like cannabis, it's 21 and over. So that was just a thought that came in mind for me with this.
I think that's a great idea. And you're right, that is an ongoing challenge, is youth don't see any of the more socially acceptable, but in the long term, most deadly drugs of alcohol and tobacco being illegal. Any other suggestions, ideas? All right, can we move to slide 11?
Sure, that's the end of this agenda item, so not necessary to take any action. It was just for a review, but it sounds like in general, there are suggestions to improve wording and inclusion of some of the objectives to be more realistic to current thoughts about substance use as well as prescribing of opioids, perhaps messaging to be more inclusive, related to school-based activities or outcomes with some of the additionally funded programs, to put some messaging into them regarding prevention. That's kind of what I heard the overall discussion. So no recommendations perhaps about what to fund, but more how to describe to be inclusive with education and meeting some of the goals for prevention. That's what I heard. So I think we don't need to take action. So I'll move on, like you suggested, to 11, page 11.
Wonderful. So closing agenda item number 3, opening agenda item number 4, review the opioid needs assessment and the statewide plan. The reports are there. And then review the recommendations from the biennial report, which will also be considered, and then the link to the DHS website. And if I remember correctly from looking at the slides, you've got those copied and pasted in the next items, is that right? Next slides?
Yes.
Perfect.
So these were just how the recommendations were made in the state plan. And again, I think your discussion previously indicated the same thing, that there's a lot of overlap. So some of the recommendations don't necessarily stay pure. They have prevention as well as treatment, a lot of overlap within that. So the next pages, and I just do a precursor because it's all yellow, was the previous group. The previous ACRN made recommendations in their biennial report. And basically they highlighted all of the recommendations that were in the 2022 state plan. So it was really hard to distinguish where the priorities really were with the group on what projects FRN staff should be considering. So there's about 4 pages of this, I think.
It is super fun to try and read on that yellow. I'm officially part of the My Eyes Are Getting Old club. So under prevention recommendations, we have establishing a bad batch communication program to alert communities and prevent mass casualties. I believe that's being worked on right now. I thought that was funded in one of the reports that I read, but I'm not positive on that. Establishing a disease investigation model for non-fatal overdoses and identify and mitigate risk. Does anyone know anything about those?
Is this part of what happens during suitors, or is that too delayed in terms of turnaround on that data set to kind of feed into this? Because that's the only investigation I know of.
Yeah.
For both fatal and non-fatal, but
Yeah, I don't know if there's anything else that's being done on that.
yeah, there
Okay.
isn't a program at the state side from a
Yeah.
equivalent to like a disease surveillance perspective that would actually do this for all non-fatal overdoses that I'm
Agreed.
aware of. Yeah.
Okay. Utilizing education awareness campaign focused on identification of the need for treatment and treatment options targeted to people using opioids and their families. Campaign should be tailored for different populations in order to promote health equity. Populations targeted should include those without housing. My recommendation would be to put this under the treatment category. That doesn't feel very prevention to me, even tertiary prevention. Increase education to decrease stigma and enhance understanding of recovery for employers and landlords through recovery-friendly workplace initiative. I think we all know what I'm going to say. This feels like it should be under the recovery pillar. Implementing mobile crisis teams with harm reduction training and naloxone leave behind. This falls under harm reduction. I know that's a project that's being worked on. I don't believe with with FRN dollars, but state DPBH dollars. And I know that it's sort of happening, is what I know. Increase education on the safe use and storage of opioids. Statewide campaign should develop consistent education and standardized guidance on the use and storage of opioids, such as Office of Suicide Prevention safe storage efforts. Should also include resources for safe disposal. I lost my place. Safe disposal of opioids, which should engage law enforcement, the state pharmacies to develop easily accessible safe disposal resources. That feels very prevention. And I know that this is happening in pieces, but I don't know that it's happening in a systematic way. Develop no barrier access to overdose prevention and harm reduction services, including naloxone and fentanyl testing. I think that's already happening. I know that everyone who gets naloxone is also able to order fentanyl test strips as well as xylazine test strips. Purchase and distribute handheld drug testing equipment to allow rapid testing of substances.
And so Terry has her hand up, Chair, and on the last comment that you made, I do know FRN does fund purchasing of mass spectrometers, sorry, I can't say it correctly, and has supported that. So I think the hard part is to know without a list of all the funded programs, whether some of these things are already happening at FRN level.
I agree. And Terry, I apologize I missed you. I was looking at the yellow.
No problem. On the recommendation about increased education on the safe use and storage of opiates, there is a recommendation coming out of Surge that covers this, and about having prevention coalitions work with pharmacies to provide kits when people are prescribed opiates, and then to do education through the Board of Pharmacy to people who work in pharmacies about co-prescribing and about the availability of naloxone free to people.
I love that. That is fantastic. Any other notes on this page? Can we move to page 14, please? Implement an education campaign on the addictive potential of opioids and alternative therapies for chronic pain, chronic illness, especially in rural areas, that is tailored to geography and underserved populations. I would wonder, is this an education campaign to prescribers, or is this an education campaign to the public? I would wonder how helpful a public campaign about non-opioid alternatives would be to the general population.
So
Maintain. Oh, go ahead.
Oh, I was just going to say at the opioid conference a few years ago, I do think the Board of Pharmacy is part of this, and also just professional organizations about treatment in general. So these are very broad. I think part of the hope would be is to target more realistic activities that FRN can then spearhead with funding. And that might not be one of them. I think there's other organizations working on that.
Wonderful. Thank you. And Heather.
Yeah, I was gonna just add that I think one of the major challenges we're seeing across our rural and frontier populations is that there's a severe shortage of healthcare professionals across all spectrums, and it's great to talk about the alternative therapies, but in reality, those services don't exist. And so even if we educate general population and or providers about it, the resources for those alternatives are often lacking.
That is definitely something I think all of us have heard in at least 15 different public meetings in the last couple of years, is there is such a provider shortage that until we address that, we really can't address a lot of the other issues. Okay, maintain and distribute naloxone kits. Although naloxone is available in public education, on the benefits and use have increased, the funding for current efforts is primarily driven by grants and subsidies, and long-term sustainability plan is needed to ensure Continued access is available, also essential to ensure that the further educational efforts are targeted and the special populations and groups experiencing disproportionate overdoses. I know that just this year, at least Clark County reached its naloxone saturation goal. I believe for the first time ever. I'm not sure where the state is on their naloxone saturation goal, but I do know that that is an ongoing problem of how long-term will we all be able to administer or give out free naloxone to our most at-risk populations. Implement universal screening for ACEs and ESPERT in pediatric care settings, reimburse Medicaid under early and periodic screening, diagnosis, and the treatment provision. So this is wanting to have ACEs and ESPERT screenings required in all medical settings. That is a lofty goal. I wonder if anything has been done about this. Okay, funding the integrated care training program. Training in the integration of physical and behavioral health can not only help to identify substance use and potential misuse earlier, but it can address other problems such as mental health issues before they contribute to substance use. Training should consider the unique landscape of rural, frontier, and tribal communities. Training should also include a focus on social determinants of health and can be tailored for opioid uses in special populations such as adolescents, transitional age youth, or pregnant and postpartum women and underserved individuals such as people of color. Okay. Develop and implement parent training or parent education opportunities, resources, and supports for substance use prevention or substance use disorder prevention. Implement public messaging campaign on the prevention and impact of ACEs. All right, I think we can move on to our next page. I think that's on there twice. Implement initiatives prior to release from prison, provide information on and connection to post-release treatment, housing, as well as education on the risks of overdose after periods of abstinence. All right, provide support for commercial sexually exploited children through receiving centers and ongoing treatment. Sway, do you, I know this is one of the targeted subpopulations you work with. Do you have any ideas, or is that happening?
Yeah, again, through our at-risk youth services, they try to address all areas of risk with the population, whether it's substance use, whether it's C-sex concerns, whether it's runaway behavior. So I think we are addressing some of that through the child welfare system. It's, again, just those populations that we are not able to reach. You know, or those ones who, kind of deny that they are involved in some of those areas, even though the behavior reflects otherwise.
Yeah, I would absolutely agree with that.
And some of that is peer protection. They want to protect their peers.
Prioritize naloxone and fentanyl test strip distribution to people who use drugs and to clinics that provide MAT services. I think that's part of the naloxone saturation plan, but I'm not entirely positive. Train providers and pharmacists on how to educate patients about pain management expectations and the risks of opioids, provide tools and patient education materials for statewide use, as well as materials tailored for underserved populations. Collaborative care agreements should fully utilize pharmacists as part of the care team. This feels like something maybe the pharmacy board would be addressing. Hopefully. Expand harm reduction products through the purchase and distribution of vending machines statewide. That was specifically called out that that's happening statewide through some of the funding. Promote youth substance misuse interventions. Yes. Provide prevention specialists for schools to support implementation of evidence-based practices in grades K-12. Implement trauma-informed schools. Prioritize naloxone distribution to people at higher risk for overdose death, requiring more systematic data collection. Effort to drive allocation of resources towards the people and communities with high death rates, as well as innovative efforts to connect with people at high risk, people who are, I'm assuming, unhoused, living alone, or living in settings which drug use is hidden. That feels very similar to the other prioritized naloxone and fentanyl test strip distribution to people who use drugs and clinics. No hands, no comments. Cool. Nope, I think you were right, Tina. Expand educational efforts in schools to promote early intervention and reduce stigma. Curricula such as mental health first aid can be an effective method of assisting youth in identifying signs of suicidality in their peers in a way that reduces stigma and increases knowledge of how to promote intervention. Continued training on the signs and interventions of suicide and substance use at schools, systems for parents, law enforcement, and other community partners will assist in reducing stigma and assisting in identifying individuals at risk, allowing for potential earlier intervention and decreased risk of lethality. There's a long way of saying we should support mental health first aid. And I know that mental health first aid is something that's fairly well known within the communities in Nevada. Continue the use of comprehensive prevention services rooted in harm reduction principles. Harm reduction can be an effective way of decreasing risk in multiple areas, from overdose to reduction of HIV and other diseases. It allows for education and intervention with active users who may be in early stages of change, and assist with linkage to treatment. Efforts should include community members, organizations, volunteers, professionals, and other stakeholders to become engaged members of the harm reduction and prevention. Workforce planning, implementation, monitoring should meaningful involve people with lived experience. I don't know how FRN was supposed to fund all of these. These are just the prevention activities. Increase the number of providers trained on trauma-informed treatment. There is a connection between exposure to childhood trauma and risky behaviors such as substance use. Nevada should consider offering trauma-informed training to all provider types, from primary care physicians to OBGYNs, as well as school personnel. Mental health first aid could be used in a school setting, as well as primary care settings, to educate individuals on the effects of childhood trauma and available resources. Education on recognizing the signs of trauma and appropriate treatment will allow for earlier intervention and prevention efforts. Provide reports on analytics from the PDMP that allow the state to identify demographic characteristics of those prescribed controlled substances for prevention of future overdoses. Is this the last of the yellow slides?
This is Sway Mackey. Is that last one already done? Is that what the Power BA presentation is, the data analytics for the dashboard?
Can you go back, Tina?
So I know Alyssa gave some information about the PDMP. I don't know if you want to make a comment about what's available, Alyssa?
Yeah, so PDMP, the dashboard, so Office of Analytics has a bunch of dashboards in relation to the substance use and PDMP. This one does show, hold on, let me pull it up, because we do have a designated PDMP analyst with our office. So it's just more of if there's something that's specific to PDMP that you want to request that's not available on the public facing dashboard, there is a point of contact. And I know that the Board of Pharmacy also hired, I believe it's now been a year, a specific data person as well that's housed within the Board of Pharmacy, to kind of help clean up or provide any other reports on top of what Office of Analytics can provide. Sorry, I like lost the chat, but I wanted to pull up and make sure I'm explaining it correctly because it is my counterpart that does the dashboard and everything. So while this loads, yeah, so I guess if you are looking specifically for opioids or stimulants, you're able to check the current status and trends throughout the last few years. Prescriptions by morphine milligram equivalent is also available. Prescriptions by diagnosis code, so why those specific prescriptions were prescribed. And kind of like the refills. I know one thing that we've worked on is what is it, like provider shopping, if that makes sense. So yeah, if people have gone to multiple providers trying to get the same prescriptions, and that is something that can be calculated and watched through the PDMP. So it does have a wealth of knowledge. I know a lot of people don't know that we do have these dashboards, so I just thought to share with this subcommittee.
I will say, as an aside, Alyssa, those dashboards are really great if you're writing grants. So those of us who work in this field and are continually writing grants really appreciate those dashboards, and we have them bookmarked.
Great, that's so good. Yes, the whole goal for us is to help anybody and everybody in the state of Nevada understand, because sometimes it's all about numbers and presenting what is even changing or what's present. So again, utilize Office of Analytics as much as you want to.
Thank you.
Okay.
Terry.
Yeah, Terry Kearns. Alyssa, I had a question. I know there's data sharing agreements with other states with the PDMP, and I just wonder what we're capturing for those areas where somebody may be going into another state because it's the closest pharmacy, for example, or are we losing any visibility on those types of people?
Yeah, that is a good question. I'm not entirely familiar for the PDMP side. I know we try to track our residents specifically in the state of Nevada and whatever is happening in the state of Nevada. So to your point, yeah, it is hard to see if anyone is going out of state. I can try to collect some more information and report back for the next meeting as well. Unfortunately, I don't have all that information on the top of my head.
Thank you. We would love that information. Okay, next slide of the yellow. Standardized clinical guidelines for non-pharmacological treatments such as physical therapy, cognitive behavioral therapy, and chiropractic care. A work group should be established with representatives from the medical and pharmacy state boards, as well as Medicaid leadership and MCO leadership. The work group could focus on education on non-pharmacological treatments and work to improve formulary coverage and reimbursements for non-pharmacological treatments and multidisciplinary pain management treatment models, including physical and behavioral health services. sounds great. I wonder if any work has been done on this. That sounds like a really big lift. Increase access to after-school summer recreation and intramural programs in grades K-12. I know we looked at some of the programs that were being funded, and I think this is something that was done through FRN dollars. Implement a school screening tool to identify ACEs and provide early intervention to children and their families. Provide appropriate referrals for treatment and counseling services. How is this different from the one that we just talked about a couple of slides ago?
It sounds similar. I think there's a lot of repetition in this. It seems that the theme really is to partner with K through 12 in whatever format necessary to create education and screening to some level in all of those in those school settings, as well as implementing after school programming where it's higher risk potentially or more beneficial. I think greatest impact. I mean, that could be some of the recommendations of the group, saying the major recommendations make sense, but the themes need to be more streamlined to impact individual communities. That's what it seems to me. And then of course there's the large system impacts that were suggested that I think are probably beyond what the advisory committee would understand on the day-to-day direct provision of services and community level knowledge. I think there's tiers of intervention potentially or recommendations, but to me, the group is well situated to talk about the real life solutions that could be implemented in local systems.
I agree.
Just my observation from what you've read through so diligently.
We are trying to follow the script. If I don't have a script to follow, I will go wildly off topic. So, implement MTSS. I think we can skip this one. It feels very much like stuff we've already talked about. Implement family-based prevention strategies, especially for transitional aged youth and adults. Invest in Families First Prevention Act activities to reduce risk for childhood welfare involvement. Sway, do you know if that's happening?
Yes, in family services, we actually have a new department, Clark County Clinical and Community Services. And the previous family services director is now over that new department, and the Family First Prevention program shifted over to that area. So what they do is they are kind of like a hub for Clark County Family Services, Clark County Juvenile Justice, and Clark County Social Services, which serves some of our extended foster care population now. So they are looking at all of those preventative measures with regards to ensuring, number one, that they have programs in place to prevent youth from coming into care when families are struggling with youth. They try to get involved right away to prevent them from even coming into the child welfare system. So, and because we work so closely knit, juvenile justice, family services, and social services through our extended foster care program, they kind of are, the clinical services team kind of works in collaboration with all three agencies, because we tend to all hit the same population of families and children.
That is fantastic. And I'm assuming no FRN dollars are going towards those projects currently?
I don't believe so. I'll look at our eligibility. I'll work with our specialists over there where all the dollars are coming in and she can tell me exactly if we're getting FRN dollars, exactly what they're being utilized for. So
work in concert with school districts to for the development of mandatory age-appropriate prevention education and educator training for K-12 grades specific to the strategic prevention framework, good behavior model, and evidence-based curriculum to include the use of naloxone and how to talk with healthcare providers when age appropriate. I know this is something that Department of Education is working on very, very slowly, but they are absolutely making strides towards ensuring that all of the prevention work done in schools is evidence-based. Because what we do know is right now, many of the programs done in schools are not evidence-based or best practices. Because teachers are not subject matter experts in finding best practices in substance use prevention. Implement child welfare best practices for supporting families impacted by substance use.
Yeah, I was going to say we are, every family that comes to the attention of child welfare, if we are not able to, or I should say, if we find that we need to continue to remain in that family's life and serve that family, then we do work with them with a case plan to ensure that they're getting substance use, treatment should they desire to attend that treatment. And, really just supporting the reunification of children by addressing some of those issues of substance use, domestic violence, homelessness, all of those things that tend to impact families.
That's wonderful to hear. All right, next slide. Increase prescriber training in grad school. Training would be more effective if mandated as part of the grad school education, medical school curriculum, buprenorphine, naloxone, methadone, safe opioid prescribing, and pain management best practices. Support increased needle exchanges across the state. Many agencies provide needle exchange services, but more sites are needed in locations where those using feel safe and anonymous. In addition, sites could expand services and include distribution of naloxone to provide education regarding recovery and treatment, as well as public health services in areas that are currently not receptive to initiating needle exchange programs. Increased education needs to be provided to help the community recognize and accept the importance of these programs and long-term impacts, not only for the communities, but for people with opioid use disorder. Heather.
Yeah, I was just going to comment on this one. In a lot of our communities and speaking with community leaders where needle exchange is a total no-go for their community. It's not something that they're going to widely accept. That TRACB does have a mail-in system that they are looking to figure out ways to expand. And we're trying to, through the syndemic plan, help promote the expansion of the mail-based program for exchange into rural and frontier communities, also for the benefit of those who are receiving those. It's not just needles or syringes, it goes beyond sharps in terms of the supplies that they can mail, but that also preserves the individual's anonymity within their own community for that. So I thought that might be just something to think about and consider for this particular recommendation here.
Yeah, I agree. And I think there has been dollars given to TRACB to expand that program for specifically the reasons you talked about. So I think that's wonderful. Develop specialized med school programs, work with med schools to offer specialized residencies or free or subsidized tuition for students who enter the behavioral health field and serve in rural and frontier communities, or with underserved populations for a specific number of years. I know that's being worked on. I don't know if FRN dollars are going to that.
Well, I do know that Dawn told us at our last meeting that there were several NRS there are several laws, and they're providing some financial assistance for specialty programs. So this seems to be moving forward.
Yep. Train statewide law enforcement personnel on the protections of the Good Samaritan law and the revised statutes on paraphernalia possession, so they're enforced as intended. Currently, the fear of law enforcement intervention may put people at risk for drug overdose, HIV infections, and other health harms. I know that's something that the Attorney General's office has been working on for a while.
Yeah, Jamie, if I may, Terry Kearns, and it was funded through the Fund for Resilient Nevada, about doing an ad campaign toward the public, but then also providing education to law enforcement. And through NOCI, the Nevada Opioid Center of Excellence, they've done a training. They're going to revise that training and make it so that law enforcement can get post-certification education for that. So there's already been a lot done on this.
Wonderful. Thank you. Align priorities of the Good Samaritan law, protections with enforcement of drug-induced homicide laws by deprioritizing enforcement of the drug-induced homicide law, which I think, Terry, you've covered in all of the trainings that are being done.
Yes, that's correct.
Wonderful. Fully implement zero suicide framework statewide, including leading system-wide culture change training, the workforce identification, client engagement, treatment, and transition to lower levels of care, and quality monitoring and improvement. Any comments on this page? Fabulous. Let's move on to page 19. Ah, we're still here. Promote neonatal abstinence syndrome prevention programs through home visits and parenting programs for pregnant and parenting persons with opioid use disorder. I know there's funding for the Empowered program, and I believe it's FRN dollars, or at least there's some FRN dollars that are going to that program, which I believe is in Vegas and Reno. Incentivize and implement expert in OBGYN settings. Create an office/position that can increase education and adoption and support for expert in all healthcare settings, similar to the Zero Suicide Initiative. Provide analytics from the PDMP providers to identify polysubstance. PDMP can be used to identify trends in stimulant prescriptions issued and dispensed, replacing some of the work done with opioid reporting to address prescribing practices, would assist in addressing issues of stimulant prescribing. Heather.
Yeah, I was just going to ask Alyssa if you're going to inquire about some of the PDMP data. Last time I spoke with them, which was over a year ago, the individual identifiers were not something that was currently being shared or explored to be shared with the Office of Analytics. Can you see if there's been an update with that? Because I think that's a huge barrier to any of these analysis requests out of the PDMP, is that there's not any identifiers, whether that's on the physician side or definitely not the patient side, that's shared with DPBH right now. So that's a barrier to actions that might be related to PDMP. But I could be wrong. There could be some updates. I was just going to ask if Alyssa can add that to her.
Yes. Hi, Heather.
Her
Alyssa Planis
request.
for the record. Yes, I absolutely can. As in just like kind of like the demographic information of each individual, or in terms of what? Again, I'm so sorry.
Well, I know that there's a button on the dashboard that looks if someone's getting co-prescribed 2 classes of substances, but
Mhm.
I don't know if there's an ability to look at other polysubstance use or any of these other kind of PDMP areas that would require more of an individual level, both from the individual level identifiers, both from like a provider's name and practice,
I
or
see.
and
Okay.
or the patients. because it is managed by the Board of Pharmacy, I believe.
Right. Okay, yes, I can definitely add that onto my list of stuff.
Thank you. Conduct anonymous school survey targeted at principals and staff to identify specific drug trends / issues in their schools. Results could inform additional training / resources for students and parents. For our data people, I know that I think it's called the school climate survey. It's the one that's actually done by principals in the years that we don't do the YRBS. How difficult is it to add questions into that survey? Or is it not even a statewide survey and it's a school district gets to write their own rules?
I'm not super well versed in the school climate survey. I've used it in the past, but I don't know what the more recent challenges look like with that particular data source.
Okay. Wonderful.
So Chair, I would also say that we did have several applicants for representation of K through 12 for our advisory committee, but those haven't been, no one's been appointed at this time. I think that might be something to encourage as well, whether it's in this report or in general at the ACRN meetings, that a representative from K through 12 might help make some realistic planning recommendations when it's involving school climate or implementing programming in those systems.
Yeah, I think that would be great once we hopefully get some of those folks onboarded. Implement safe baby courts for families impacted by substance use. Sway, I believe you said that's already happening.
Yeah, at child welfare, we started working with Safe Baby Courts a little while ago. We piloted it with the program, so we're trying to get it through all of our zones working with Safe Baby Courts. So yeah, that project did start. I can get a status on kind of where they currently are, but I know that it had already started last year, I believe.
Wonderful. That's great news. Create an Office of Strategic Initiative as recommended by the DHHS Task Force to coordinate activities across DHHS programs supporting families impacted by perinatal substance use. Offer MAT providers training and incentives for participation in the patient-centered opioid addiction treatment model, incentivize treatment and recruitment of retention for individuals with opioid use disorder for the PCOPE model to Medicaid, implement procedures and policies necessary to operate the model. We are really asking Medicaid to do a lot. Partner with surrounding states to share PDMP data. State leadership should work with neighboring states to establish a way to share PDMP across state lines. There's partnership with 34 states and share data with 4 bordering states, 4 of the bordering 5 states. I believe California is the one that does not share data. Oh, there we go. That is the answer to the question. And it's a significant barrier for monitoring harm. Next slide. Promote SBIRT for primary care. I'm going to skip this. We have talked about SBIRT and how it needs to be implemented like 20 times. Not really, but promote careers in behavioral health through early education, workforce development, etc. I know this is being done statewide. There's the Be Here Nevada program that's specifically working on that, as well as all of our AHECs. Address stigma among provider types, enhanced education and training practices with strategies to influence provider attitudes and reduce stigma, can increase provider willingness to offer treatment and recovery services. Anti-stigma training can also benefit all of those people. I know that that's something that state DPBH is working on right now, is a pretty major stigma campaign. So hopefully that will address providers. Establish supervised drug consumption sites. Skip right over that one. Implement marketing and communications campaigns to combat stigma to the general public. Again, I think the state is working on this. Establish an advisory board that informs implementation of harm reduction services that includes people in recovery with lived experience and people currently using drugs. The board can provide oversight and inform equitable and ethical integration of harm reduction services into routine public health services. Establish home visiting programs for families at risk or impacted by opioid use disorder. I am assuming that falls under sway your jurisdiction, and that seems to be already happening. The home visiting programs.
We only really have a requirement to visit the families of those kids who are in the care of who have already come to the attention of child welfare, and we've opened a case for under like a home visiting for prevention. I'm not really sure that that's happening. Like I said, some of our clinical services, if they come to the attention of someone saying that they want to surrender their child to the child welfare system because of a lack of, support in the home, whatever that may be, is, child's behaviors or, an adoption that, isn't kind of going the way they thought and they want to surrender that child, then we get our clinical services involved. I know that they may go out and kind of see how they can support that family, but as opposed to like a ongoing thing from the child welfare agency, that's not something that we do unless that family is already and the attention has been brought to the attention of child welfare, and we've opened a case on that family.
Got it. So not at risk, but folks who are already involved in the system. Okay. Evaluate key partnerships. Nevada can work with CASAD and targeted organization to identify physician champions with addiction treatment experience to serve as consultants or mentors towards peers. Right, next slide, please. Hallelujah. So I think one of the goals of this was to look at everything that's been done and try to create some prevention priorities that are not 8 pages long.
Right.
So I think some of the things that we saw that were kind of continuing themes is working on prevention with youth through schools, through subject matter experts such as certified prevention specialists to ensure that evidence-based programming was being done, integrating ACEs training into those programs and with youth, obviously not just in school, but in after-school programs. So that seemed to be an ongoing theme. I saw another theme of working within the child welfare system to, I'm going to say it incorrectly, Sway, please tell me what the right words are, but to kind of stop the cycle of abuse, substance use, etc., to really work on getting families to not continue that generational trauma, and to work in all of the areas that we have access points to address those harder to reach populations.
Yeah, like I said, our clinical services division, they have Families First Prevention has shifted over to them. So I definitely could reach out to that director. I know that they are looking at kind of, a model. They also have the truancy prevention program over there. So they will be able to target some of the prevention areas that we've discussed here today. And then over on our side of the house, again, we have our CSEC, our at-risk youth team that covers our CSEC population. And then just, the children who are already in our care, trying to really get the families to a place of reunification so that those children and those youth don't go down that path, and putting whatever services in the home that we can so that they don't go down that path. So I think, between our agency and our clinical services division, we can work to come up with a good strategy for some prevention areas.
Wonderful. And Terry?
Yeah, Jamie, I'm sorry, I didn't think about this till just now, but looking at the prevention for at-use risk and going in the home, I know a couple of counties have stood up the most mobile outreach support teams for directed it toward youth. So that might be something that addresses that the prevention area for at youth of risk and for youth and families. And that could be expanded to other counties.
Wonderful. I love that idea. And then kind of the third priority I noticed was stopping access. So increasing safe disposal, increasing non-opioid alternatives, and stopping overprescribing, and kind of monitoring what the drug supply looks like. Those feel like the three big buckets that we could put most of these priorities in. So if it's possible, because I know this is not a voting item, Tina, I would love if we could workshop that, come up with strategies, etc., underneath those that would be a little bit more achievable and focus on priorities that I think we have more ability to change. Because I don't know that the ACRN and FRN dollars could be used for some of these more esoteric projects.
So the agenda item, really, we could take action. I don't know what the action would be other than to devise. Now, you don't really necessarily have to take a vote, but it sounds like the intention is to convey to FRN that there are themes, obviously, and the group would encourage support financially to those systems changes that are related to school-based programming and youth, child welfare support. And then Terry mentioned the youth directed most, but I think what I hear you saying is these are large preventative strategies that need to be honed into more affordable and financeable projects that support the themes you just suggested.
I think that is a very eloquent way of putting my words. So thank you.
Yeah, I mean, obviously, I appreciate your effort to go through that long list and perhaps give some idea to Heather about how to more finally focus some of the activities for FRN dollars, because a lot of these things you listed are huge system changes that have some impact if there was money given to them, but probably the structural programmatic changes are way beyond just giving money to the project.
I agree. Okay, so let's close agenda item 4, open agenda item 5. Subcommittee membership growth and recruitment, recruitment strategy. Adding additional subcommittee members. We are able to add members of the public as subcommittee members. And I guess, Sway, I would love if you had any ideas of people who aren't currently on the committee that should be added to the committee. I have some ideas, but I want to hear yours first.
You know, let me look and see if someone from our prevention area is interested in joining the committee. I think that would be you know, a good add. And they can tell you specifically what they are doing over with regards to some of these areas. So yeah, I can reach out to the director over there and see if they'd, you know, like to join or have a representative from their area join.
I think that sounds perfect. Anybody else you can think of?
What were your ideas?
Well, there are a couple of people who are great subject matter experts who happen to be here today who are not on our committee, and I would love to invite Heather and Terry and Shayla if she's available to sit on our committee, because I think these are great subject matter experts in different areas of kind of what's happening statewide on these projects. But we won't nominate anyone who doesn't want to be nominated.
This is Heather. I would be happy to participate in this committee, the
Thank you.
subcommittee. Thanks.
And Terry's giving a thumbs up. The other, oh, and so is Shayla. Fabulous. It was like, I'm not going to put her on the spot if she doesn't want to be put on the spot. So thank you, Shayla. And then the other member who I know sits on our larger committee is Anna Elizabeth Northen, and she's a subject matter expert on prevention. She oversees the Nevada Certification Board, which oversees certified prevention specialist peers and CHWs. So I would love if we could invite her as well. So are we able to invite all of these people and vote them in at the next meeting, Tina, or can we vote them in now?
So the bylaws allow for the subcommittee chair to appoint members at will. So there isn't an election or anything. It's at your discretion.
Perfect. I love when I can just make things happen. Terry.
Yeah, Jamie, I was just going to suggest that somebody who might be able to provide more optics into some of your rurals are the regional behavioral health coordinators, or not maybe all of them, but they would be good resources for this committee.
I agree. I'm thinking Valerie Coape makes the most sense since she's got the most longevity at this point, and she serves some of our most frontier communities. If you disagree with me or think someone else would be better, please let me know.
Yeah, no, I think Valerie would be great.
Okay. Wonderful. So I'm going to go ahead and appoint to our subcommittee Terry Kearns, Heather Kerwin, Shayla Gransberry, Anne Elizabeth Northen, and Valerie Coape. Oh, and the representative from Child Protective Services in the prevention area that will be representative that Sway will volunteer to attend. Does
So
anyone
should I-
else have
Let
any
me reach out
suggestions?
because that's a completely different department, so I can't mandate that they participate, but definitely can reach out and let them know the need.
Wonderful. I think that would be great. All right. Well, 3 of our members who don't need to be reached out to. Tina, if you could just, when we're doing our poll for our next meeting, if you could just include those folks. I will call Valerie this week and tell her that we volunteered her for more work. I'm sure she'll love that. And Sway will connect, I'm sure you with the other folks. And I'll let Anne Elizabeth, who's already reached out to me and said she would like to be on this committee, know that I volunteered her for this committee. So everyone's got something on their to-do list, but Tina, is there anyone who's been nominated who you don't have their email address for?
Just whoever Sway's contact is, so we'll wait to hear from her.
Okay, perfect. All right, did we get everything on this agenda item done?
Yes, we did.
Perfect. Let's close agenda item number 5, open item 6.
Oh, sorry, I'm falling
That's
asleep
okay.
here.
Review of upcoming meeting topics and timelines.
So for this one, Chair, I really wanted just to make sure for the biennial report, we do want to obviously include any recommendations or observations from this subcommittee. So I wasn't sure if the group wanted to meet at least one more time. The biennial report is due June 30th. So obviously would appreciate if the group had some final thoughts or information for the report and they needed another conversation that we have in the next month.
I think that's reasonable, and then we can take this to the larger group in a May meeting and then give you guys more than a week and a half to write all of our ideas down into one coherent project. Is that a good timeline? So end of this month for our finalization of the buckets and some fundable ideas. And that's what we'll talk about at our next meeting. Then that will go to the larger meeting, which will be voted on sometime hopefully in mid to late May. And so that would give you all a month to write the project, assuming we could get all of those voted on in May.
Sure. So if I understand you correctly, if we wanted to try and see about having a meeting towards the end of April, if we had the agenda, I could probably get that scheduled based on the open meeting law requirements and review process the last week of April, if that worked for people.
I can make myself available. Sway, does that week work for you? I mean, obviously not every single hour of every single day, but in general, you're not out of town or anything.
I will be at a conference from the 21st to the 25th, and then I'll actually be out on the 28th and 29th of April.
Okay. So if we could try for the Thursday or Friday, the 30th or the 1st of May would probably work. And then we can go maybe into the 4th or 5th. Give us a full week of time. Does that week after work for you as well? Again, in general.
Yeah, the week of the 4th through the 8th works great for me.
Wonderful. Okay. So Tina, I can get with you after the meeting and give you some specific times and dates that work for for me, and we can go ahead and get that doodle poll out to everyone. Please don't send it until I call Valerie and let her know that I volunteered her for something.
Okay,
And I think that's all we need for agenda item 6. And is item 7, it is public comment, and we have new people. So let me read this one more time. This is the second public comment period of the meeting. To provide public comment telephonically, dial 775-321-6111 and enter conference ID 634-991-514#. Comment should be limited in no more than 3 minutes. No action may be taken on a matter discussed under this item until it is included on the agenda as an item on which action may be taken. If you are in the room, feel free to use the raise hand function and you will be welcome to speak. I see none. Tina, is there anyone on the phone who's called in?
No, there is not.
Perfect. We can close this, and I believe we can move on to wrap up and adjournment. Thank you so much, Tina, for putting all of this together, and all of you for being such wonderful participants in this a little bit tedious process. Thank you so much. I think this has been wonderful and will hopefully create a more usable framework for ACRN and FRN. And we can go ahead and adjourn at 10:53.
All right. Thank you, everyone.
Thank you.
Thanks, everyone.
Thank
Have a
you.
good day.
Bye.
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 Okay, so April 30th, I am open anytime except for 11 to 12.
Okay,
And on the 1st, I'm available anytime after 11.
okay,
The 4th, I'm available anytime after 1 o'clock. I have the BH Pack meeting in the morning. And then the 5th, I have nothing, so I'm available all day.
okay. And did you want the 27th or no? Of April? That's a Monday.
I am actually out that day.
Okay,
I'm on
so,
vacation that day.
sure, okay. Well, then I have your dates, so I'll wait until you speak to Valerie to
Perfect.
send the doodle. We also have an appointment to subcommittees on the next ACRN meeting on Monday, so just to let you know that. I sent you the PowerPoint, so you can look at that, but thank you for getting through all of that. I think it opens up a lot of opportunity to refine some of the guidance to FRN.
I agree. I want them to have something that isn't just a laundry list of everything in the world, but some actual projects that will make a meaningful impact in Nevada.
Absolutely. So, oh, I can stop sharing now, finally. Okay. Well, thank you so much for your leadership, and then I will get working on this.
Sounds great. Thanks so
Okay.
much. Have a good
Thank
day.
you. You too. Bye-bye.
Bye.